Doctors, we shall go on to our next speaker, Dr. DEEPA Gupta, and she's a consultant at Lal Eye Care from Gurgaon and a cataract, cornea, and refractive surgeon. And she's going to show us another form of subluxation and how she managed it. On to you, Dr. DEEPA. Could you unmute yourself? You're not heard.
Yeah, thank you, ma'am, and a very happy Diwali to everyone. I shall be again showing a similar kind of a scenario as Aditya had shown earlier in his talk, in his wonderful presentation rather. So I'll be just starting with my video. Yeah. So this is a story of a 50-year-old male. He presented with the bilateral subluxation of cataracts, but he had a history of trauma in one eye, but not in the other. But the main crux here was that it was a hard cataract, and the subluxation was seen.
About the volume, we hear you. We can't.
Yeah. So it's almost a 180 degrees subluxated cataractus lens. So I did stain the capsule. We should always stain the capsule before we put in a CTR, and followed by a gentle hydrodissection and viscodissection to move the nucleus. So here I'm going to put a CTR.
We can't hear you.
Yes, ma'am. So as you can see, the CTR is going in the bag. I'm sorry for a bit of a decentration, I think. But now, as we can see, the bag is, it is, the subluxation can be appreciated in this. And we just have to, gently crack the nucleus and mobilize and bring out segments, nuclear fragments, and phacoemulsify them one by one. So once it is done, the IA can become a little difficult in this situation, as the cortical fibers, they get entrapped in the ring. We gently have to nudge them and move them side by side and kind of aspirate them. So now we can see only this chunk was left, and now the last bit of cortical matter, I'm going to remove it. So we can appreciate that the bag, it really stabilizes with the CTR, and the cortical aspiration, the nuclear removal and everything, it saves, it kind of becomes easier. After the total bag cleanup, I'll be putting the IUL. And he was happy. So his other eye actually had vitreous and AC on this side, and he gave a history of trauma. So first I did the anterior vitrectomy, followed by a similar approach, did a little capsulorhexis and further enlarged it. So whenever we are putting a CTR or a CUNY, our capsulorhexis has to be, large enough to. So in this, I could actually take the nucleus out before the putting the CTR. But when I started doing phaco, the bag, actually I saw it, fluttering. You can see the nucleus dangling, and it became vertical. So I again pushed it down. I again push it back in the bag and then put a CTR. You'll just see it again now. So now you can see that the nucleus is actually moving. So I put it back again and then inserted a CTR. So then it was actually easier to bring the whole thing out, the nucleus out, and complete the phacoemulsification. And by similar chopping technique, I could finish the surgery. And similar kind of a IA, in similar fashion, the IA was performed, and the cortical removal was done. Finally, you could place the single piece IOL again in the bag, and the patient, so the IU was completed and the surgery was finished. So how I approached it.
Thank you very much, Dr. Deepa. That was nice videos you have shown. Only thing I was wondering that the area of zonular weakness is more than 4 clock hours. I may be wrong. So maybe a CTR alone may not be adequate. You could have used CTR segment 2. Our question to you, Dr. Purendra Vasim, how would you propagate your excess in an area when there is a subluxation? I'm sure we would not want a large rhexis. We want a right size rhexis. We don't want small rhexis because we don't want a phimosis to happen. But I don't think we would want a large rhexis either. But how would you go about doing propagating your rhexis?
I thank you. I'm sorry that I could not join earlier. The thing is that in subluxated cataract cases, the capsule itself is very lax. It is not easy to do capsular access with the needle. Better to do with the forceps, and because you can control it in a better way. Now, positioning of the rhexis should be such as per the subluxation of the lens. If your lens is subluxated or deviated to one side, so your capsular exit should center the lens, not the center of the eye or center of the pupil. So that has to be kept in mind. It should be, initially it appears to be slightly eccentric. And lastly, it should not be too small, neither it should be too large. I don't care if it is around 5.5 millimeter. If it is too large, then it becomes very difficult to push in the CTR also, and the lens capsule, which is to cover the margin of the lens, optic of the lens, that also is inadequate. So this is what I do, and we have to keep the chamber filled with viscoelastic, and the anterior capsule should remain flattened throughout the process. Otherwise, the vitreous will come out and everything will be messed up.
You don't want shallowing of the AC, and also I think you should come to the area of zonular weakness. That should not be, the rhexis should not start from there. It should start away from the area of
from the area of zonular analysis.
Yeah,
absolutely.
Yes, Dr. Anaga.
Yes, ma'am. I would also like to ask the panelist, Dr. Sanjay, sir. Would you think flax would have been a good option in this case, because we have the option of centering the capsulotomy on the scanned capsule? So in such cases, then the difficulty in making the capsulotomy also would be obviated by the use of flax in these cases. And another thing was, maybe you could have used capsular hooks in the beginning, done a gentle hydro, freed the nucleus, and then put in a CTR. Then there is greater stability to the capsular bag. Yes, sir. Dr. Sanjay, sir.
Yeah, see, your second point, at what time to put in a CTR?
Yes.
I really feel that what the video showed, that if you try to remove the nucleus first, the whole bag starts dangling.
Yeah, that's what
it becomes difficult to take out the nucleus, right? So once you've done the rhexis and the hydro, that is the best time to put in a CTR. So that stretches the bag, that brings the bag more into the center, and it loosens up the nucleus so that you can easily pick up the nucleus and emulsify it. So that is the standard option. Now the option of making the rhexis by techniques other than a needle or a forceps, you have Zepto and you have Femto. Now, in any case, Femto does work because you have a good control on it. But if the bag is more mobile, with every shot there is a little movement, but a Femto is kind of able to overcome it, and you can make a rhexis. It's doable. Zepto is dangerous because your zonules are already weak and you are causing a lot of suction on the anterior capsule and making a rhexis. But if your zonules aren't too weak, that means if it is just 3 o'clock dislocation or less, then even the Zepto works very well, because the Zepto you can kind of guide it under the iris, and then hold the center, and in a flash make a rhexis, which is also very strong. But still, I think a needle or a forceps works very well, and that should be the routine choice for everybody.
So in Zepto, I think the chamber fluctuation is very high. When you're removing the Zepto probe, then it doesn't collapse on itself. You remove it, just pull it out. At that time, the viscoelastic also comes out, the chamber shallows. So then in case of an already subluxated bag, it becomes a little more challenging.
True, that is what I said. Though these techniques are not
In case of a
the
nucleus,
needle and forceps is still the best way out.
still better, yeah.
Dr. Jain, if there is a capsular phimosis, we don't see those things happening much at all. But if a person has erred to make a small rhexis, has not given good support to the capsular bag, can you advise how would you deal with it? Very briefly, just a line answer.
Briefly, first of all, we have to, prevent doing a small rhexis.
Yes.
Even if you do a small rhexis, at the end of surgery, you can enlarge it after injecting a viscoelastic. I have
Yes.
done it so many times.
Yes.
So, if at all phimosis happens, you can again enlarge it at
Yes.
any time after injecting viscoelastic under the bag. If it has become too fibrotic and it is not amenable to capsular rhexis forceps, I have even done with the vitrectomy probe also, the enlargement of phimosed rhexis.
Dr. Basin, would you do something else before we go on to our next speaker? Would you think of doing an
No,
laser?
I would do YAG.
laser? Yes.
Pardon?
Yes, that's what
YAG laser.
Yeah.
YAG laser, low energy shots at the margin and at multiple places.
Yes.
That will help us.
Yes, thank you. We
And
shall.
that is non-invasive.
Yeah.